Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors, Strongbridge Biopharma, Pfizer, Novartis, and our expert presenter, Dr. Nelson Oyeshiku. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors to bring valuable resources and programs for the patient community. Today's webinar title is Implications of COVID-19 on Patients with Pituitary Disorders. Our presenter is Dr. Nelson Oyeshiku. He's the Director of Pituitary Center at Emory University, the Al Lerner Chair in Neurosurgery, Professor and Vice Chairman of Neurological Surgery, and Professor of Medicine at the Emory University School of Medicine. Dr. Oyeshiku's clinical and research focus is the surgical treatment and molecular biology of pituitary tumors. Dr. Oyeshiku has performed more than 3,000 surgeries for pituitary tumors, is one of the few surgeons in the US and worldwide, and the first in Georgia, utilizing advanced 3D endoscopic surgery for resection of pituitary tumors. This technology provides the surgeon with improved spatial resolution, making surgery safer. Dr. Oyeshiku partners with Dr. Adriana Iagomescu and a team of clinicians who collaborate in the diagnosis and treatment of patients with pituitary tumors at Emory's Pituitary Neuroendocrine Center, which has a nationwide and worldwide referral base and provides patients with comprehensive and personalized medical and surgical management of pituitary disorders. Dr. Oyeshiku is also director of the Laboratory of Molecular Neurosurgery and Biology, which is dedicated to unraveling pituitary tumorigenesis. The laboratory's pituitary tumor bank and database allows clinicians and researchers to provide patients with advanced molecular biological analysis of their tumors. The laboratory was the first to identify unique aspects of pituitary adenoma gene expression and was the first to discover a key molecular marker for non-functional pituitary tumors that has enhanced the understanding of these tumors. Dr. Oyeshiku and his team of researchers also developed a new modality for imaging pituitary tumors. This molecular imaging diagnostic tool was pioneered and first utilized at Emory for patients with pituitary tumors. The molecular imaging allows doctors to identify a key tumor marker in patients with clinically non-functional pituitary tumors non-invasively, thereby identifying potential patients for a new targeted chemotherapy. The research team is currently undertaking this potentially groundbreaking new drug therapy for non-functional tumors that could lead to the first drug therapy for clinically non-functional pituitary tumors. To date, there has been no medical therapy available for patients with clinically non-functioning tumors. Dr. Oyeshiku, we appreciate you taking the time to present this very important, timely topic for everyone. There's going to be a brief delay. Actually, we've already changed presenter, so there won't be a delay. You can already see Dr. O's screen, and we are done on our end. Dr. Oyeshiku, it's all yours.
Thank you very much, and good afternoon, everyone. Happy Mother's Day to the mothers in the audience, and I wish you all a very healthy time during these rather challenging period for the country and the world. So, and thank you very much for the introduction and the invitation to participate in the PNA webinars, which are of great educational importance to our patients and providers. So would like to delve into the issues of the COVID-19 pandemic and how it relates to patients with pituitary disorders and pituitary patients. So the coronavirus disease 2019, or COVID as it's known for short, is an infectious disorder that causes a severe acute respiratory syndrome, also known as SARS-CoV-2. It was identified in 2019, hence the name 19, and it's an ongoing pandemic, as everyone by now knows. As of today, last I checked, there were over 4 million cases worldwide in about 187 countries and territories, accounting for well over 200,000 deaths. Fortunately, about 1.37 million have recovered. As you've, I'm sure, heard by now, the symptoms are typically upper respiratory in nature, may involve a dry cough, fever, a generalized malaise or feeling of being unwell, shortness of breath, loss of the sense of smell, medically known as anosmia, and the sense of taste, agousia. It may be a mild, even asymptomatic disorder. In other words, the patient is completely unaware of the fact that they have been infected with the virus. Or it may be very bad, leading to severe acute respiratory distress syndrome, the failure of multiple organs, even septic shock, intensive care treatment, blood clots, and so on. And ultimately, regretfully, a lot of patients will succumb to the coronavirus. Exposure to the virus can lead to disease in as little as a few days, with a range of 2 to 14 days. Hence, as I'm sure you may have heard, the reason for quarantine for patients who have been exposed, so that during that period of time of 14 days after exposure, if they develop symptoms, one can then detect that they've developed symptoms, keep them isolated, and if they're asymptomatic, have them get better without having to infect other people. And of course, if they're sick, then of course needing medical attention. We already know by now that there's person-to-person spread, usually requiring close contact, hence the 6-foot social distancing recommendation. It may spread by droplets, as in when one coughs or sneezes, or even talking. Those droplets, if they reach contaminated surfaces, can then spread to other people who then touch the same surfaces, and then touch their face or nose or mouth or something like this. And so the infection then spreads by fomites, as it's called. Several diagnostic tools have been and are continuing to be worked on. The most popular is the swab. In other words, a little cotton swab that you've seen inserted into the nasal passages to obtain material that can then be subjected to analysis using the PCR or polymerase chain reaction to obtain the diagnosis. I won't go into other details of different tests, as you may have heard that there are lots of other tests being worked on in various countries, and as those become available, they'll be deployed. Now, this is one area of medicine where prevention is worth an ounce of prevention is worth a pound of cure, as it were. Hence, the recommendations by agencies such as the CDC and so on to stay as much as possible at home, the so-called stay-at-home orders, to reduce the risk of being exposed. Because in order to be sick, you have to be exposed, first of all, to contract the virus. Avoidance of crowds and limiting close contact with people who are not immediately in your space to reduce the risk of transmission either by you to others or from others to you. Along with that is the admonition to avoid non-essential travel to areas that you might contract the disorder from, or in planes, subways, that sort of thing, where there's a high likelihood of contracting the infection from others at close quarters. Regular hand washing with soap and water, very effective because the soap causes the virus to be destroyed. You have to do it for at least 20 seconds so that you have enough time to allow for the virus to be destroyed by the soap and water. And certainly before eating, drinking, after restroom breaks, after you blow your nose or cough or sneeze, that allows you to get rid of the virus if you have it rather than transmit it to others. In the absence of soap and water, alcohol-based sanitizers work, those that have at least 60% alcohol. Another way of limiting spread and preventing infection to others is the wearing of masks, surgical masks, cloth masks, covering one's nose and mouth when coughing and sneezing with a tissue or the flexed elbow, and then disposing of the tissue in the trash where it cannot affect others. And avoid touching the nose, mouth, or areas around where you can get transmission into the nasal passages. So these you've heard abundantly in the lay press and so forth. Let's talk now specifically about pituitary medicine, pituitary patients, and those who suffer from pituitary disorders and tumors. As with everything pituitary, and I'm sure many of you who have been in and around the PNA know that multidisciplinary input is very, very important in the care of pituitary patients. Multidisciplinary meaning that one needs the input of different specialties, such as your family medicine, endocrinologist, reproductive medicine or gynecologist and obstetrics, pediatric if it's a child, neuro-ophthalmology, radiation oncology, and so on and so forth. And these multidisciplinary inputs are just as important during the COVID pandemic to help understand, diagnose patients and stratify the risk of a patient and guide treatment, timely treatment, and monitoring of the disease condition. Because of the burden of the pandemic, we have in many centers across the country, there's been the reduction or minimization of outpatient attendance in clinic so as not to enhance the spread of disease to patients or to patients and caregivers. And many of you may have already participated or will be participating in the use of telemedicine by video conferencing or audio conferencing, telephone with your caregivers to maximize clinical evaluation and discussion when clinics are closed. This has been shown now to be a rather effective means of delivering care, obtaining firsthand information for patients and their families, and I have personally been using this over the last 7 weeks. If a pituitary patient is diagnosed or has recently contracted the COVID-19 infection, then there's urgency for that telemedicine appointment to be able to identify problems and decide which things need to be treated urgently and stratify the patient's risk. So in those scenarios, the telemedicine appointment needs to be taken rather quickly. It is important to note that pituitary tumors and per se do not affect the immune system, although pituitary conditions most certainly do, and we'll go into some of those. As you know, comorbidities, in other words, other associated disease conditions accompanying a lot of pituitary conditions. For example, these include diabetes, in patients with Cushing's, for example, or patients with acromegaly, for example. And diabetes is a significant factor in the morbidity and the severity of COVID infections. Hypertension, also in patients with Cushing's and acromegaly. Obesity, same thing, patients with Cushing's and other pituitary conditions such as hypopituitarism. Cardiovascular disease, same thing for the functional tumors, and hypopituitarism as well. So if you look at all these comorbidities that have been defined as being very important in the COVID infection, a lot of these conditions are present and prevalent and severe in patients with pituitary conditions. And therefore, these comorbidities must be intensively investigated and intensively treated to prevent serious consequences in the COVID pandemic. Now, let's start out with adrenal insufficiency and Cushing's, and then we'll go through the other pituitary conditions in a stepwise fashion. Adrenal insufficiency is very common in patients with pituitary conditions. It's usually in that scenario, secondary adrenal insufficiency. But there's also the case of primary adrenal insufficiency as well. And this means that the adrenal glands, which produce hormones, vital hormones such as steroids, are not producing these hormones in sufficient quantity, which places the patients at significant risk for the COVID-19 infection and a higher risk of complications. In fact, adrenal crisis could be triggered by the infection, and the infection could certainly worsen any conditions of adrenal insufficiency. Most patients with adrenal insufficiency already know that they must take their medications as prescribed all the time, and must at all times have adequate, appropriate supplies, oral as well as injectable supplies, for managing routine maintenance of adrenal function, but also in cases of stress and sickness. And nothing could be more stressful than an infection, obviously. So you have to continue taking the medications as prescribed. And because a lot of things are closed, things like pharmacy and such like things, it's very important to maintain an adequate supply of these medications at arm's length at home, so that you don't have to run off to the pharmacy and find it closed and not being able to get one's medicine. Patients with adrenal insufficiency already know the rules regarding the sick day rules, as it were, where in the event of illness or feeling unwell or fever, that sort of thing, you have to up your medication. Usually you have to double that dose, and then notify your physician, properly hydrated, rest, and so forth. These are the classic sick day rules that patients with adrenal insufficiency have to live with. And any acute illness can certainly precipitate the need to up the dose of medication. Certainly, if a patient with adrenal insufficiency falls sick with symptoms that look like COVID, such as fever, cough, shortness of breath, that must immediately trigger a call to the COVID-19 hotline and your physician, so that they're immediately alerted to the possibility that you may require intensive, close evaluation and treatment. All patients with adrenal insufficiency must be equipped with a medical alert bracelet or necklace, so that if an emergency occurs and an EMT or first responder arrives at the scene, they can easily see that and be immediately aware that they're dealing with patient with adrenal insufficiency. Now, Cushing's is the exact opposite of adrenal insufficiency. In this scenario, in Cushing syndrome, there's an excess, too much of steroid, not too little. And in this scenario, it's just as bad because now you have immune suppression. The immune system is suppressed. And so the ability for the immune system to respond to infections is affected greatly. And there's greater risk of infections. And certainly if it's moderate or even severe Cushing's, this requires urgent attention and medical treatment by the endocrinologist and the primary care physician. Because of the importance of Cushing's and the severity of Cushing's in the overall medical condition of patients, many physicians are continuing to have to evaluate and manage Cushing's even in the face of the COVID-19 infection. And so, for example, evaluations such as salivary cortisol, which is a very important part of the diagnostic workup, has to be avoided because of the risk of viral contamination from the saliva or the infection of laboratory staff by salivary cortisol. So we have to look at using other diagnostic parameters because it's not clear as to the risk of transmission of COVID-19 viruses in this medium. The other thing that's important, the diagnostic workup of Cushing's in the light of COVID, is that we have to look at doing the CT scans of the thorax, abdomen, and adrenals, which could be a repository for tumors causing Cushing's in the adrenal or in the lung. As you know, the greatest percentage of cause of Cushing's is in the pituitary. About 80% or more of Cushing's syndrome is due to a pituitary adenoma in causing the problem. But because of the potential of cancer lurking in the adrenal or the lung as a causative factor in Cushing syndrome, it's very important in this pandemic to evaluate that, because those patients obviously need surgery and need to be moved very high up on the surgical list. In terms of temporizing or treating Cushing's temporarily during this period of time of Cushing's, medical therapy is a very important adjunct. We know that the best treatment for Cushing's disease is pituitary surgery, but as we'll get to in a little while, pituitary surgery may not be an option during this period of time for reasons that I will talk about in a second. And therefore, to mitigate the clinical syndrome and to treat patients during the time period where they are awaiting surgery, medical therapy with medicines that can inhibit or dampen the generation of steroids, so that cortisol is important. Patients with severe Cushing's should be treated prophylactically, in other words, in a preventative management modality with pneumocystis, which is an infection that preys on patients with depressed immune systems. If a patient develops cough, fever, or respiratory distress, it's very important to differentiate that infection, potentially COVID-19, versus other pulmonary infections that are common in patients with Cushing's syndrome. If the patient has a severe case of Cushing's with multiple problems, diabetes, hypertension, infections, poor wound healing, fractures, etc., and despite treatment with medicine, the physician still has a difficult time controlling high levels of cortisol, or the patient has serious side effects that preclude them taking medication to cut down on cortisol production, those patients should move to the top of the list for surgery. And in that scenario, obviously, they will need a test for COVID-19 to make sure that that is negative, or and if it is negative, they can proceed with surgery under the care of a very experienced pituitary surgeon. In cases of positive COVID in this situation, if the surgery does have to proceed, it will need to be proceeded with a high level of personal protection and guidelines for the OR team and the hospital. We'll get to those in a moment. How about other pituitary conditions? So we're going to talk about the growth hormone tumors, the ones that cause acromegaly or gigantism, the prolactinomas, and the non-functional tumors. So in patients who have been diagnosed with mild acromegaly based on clinical symptoms, laboratory investigations, and do not have visual compromise. In other words, the tumor is not big enough to cause or not or causing pressure on the optic nerves. Those patients could certainly, during this pandemic where things are stretched thin, could certainly defer evaluation or management if they have difficulty reaching specialty care or things are limited because of the pandemic. Of course, deferring it with continuing monitoring of these situations. Patients with moderate to severe acromegaly who do not have problems with vision because the tumor is not causing pressure on the optic nerves should be treated medically with somatostatin receptor medications or growth hormone receptor medications such as pegvisomab to control disease during the period of time when the patient is awaiting definitive treatment with surgery, for example. Patients with micro, in other words, prolactinomas that are smaller than 10 millimeters or a centimeter, or macroprolactinomas greater than 10 millimeters, but have no visual complaints or syndromes, again, may either be treated with dopamine agonist treatment with medication for symptom relief, or may decide to wait until they can decide on definitive treatment, medical versus surgery. As you know, the first line, for the most part, with patients with prolactinomas is medical therapy with dopamine agonist medications, which are taken orally. And so for the majority of patients with prolactinomas, they do not need surgery. For macroprolactinomas, large tumors that are causing deterioration in vision, they need immediate treatment with dopamine agonist drugs, things like cabergoline or bromocriptine, close monitoring of vision to make sure that they are responding adequately to the medication. And if they're not, then of course they need to be moved to the top of the list for consideration of debulking surgery to remove the compression on the vision. The non-functional tumors, non-functioning meaning tumors that are not producing an excess of hormone, such as prolactin, growth hormone, and cortisol. Those tumors, if they're small, don't have any mass effect or problems with vision, can be monitored during the time of the pandemic. However, if vision deteriorates either subjectively or objectively, that patient needs to be evaluated, preferably by telemedicine, and have a visual study to decide whether surgery is warranted for urgent debulking. Those patients also can have hypopituitarism, which, as we've discussed, can modify or cause the COVID symptoms, if they have an infection, to be more severe. So hypopituitarism from any cause obviously needs management to optimize the medical condition of patients. Many patients will need follow-up, routine follow-up. For example, patients who have functional tumors who have been treated and are in remission, or some that are well controlled on treatment. For folks like this, they can be followed reliably using telemedicine and not have to come to the clinic to expose themselves to the potential of infection or transmission of infection. Patients who have been, before the pandemic, being considered for radiotherapy for whatever reason can be safely postponed until when the pandemic is over. Imaging for follow-up, MRI imaging and that sort of thing for routine follow-up should be minimized to reduce the risk of transmission. And then the imaging can be picked up later on down the line, with the caveat that clinical monitoring and clinical follow-up must be maintained at all times. Because of the stress on the healthcare system, many of the imaging facilities are not at full speed as one might expect. A lot of patients with pituitary condition have fluid and electrolyte problems from conditions such as diabetes insipidus and have fluid as well as electrolyte problems. Usually these are patients who have things such as craniopharyngiomas or have had previous surgery for pituitary tumors or have had hypopituitarism from pituitary apoplexy, those kinds of things, or had things like hypophysitis. Regardless, these patients with fluid and electrolyte problems from diabetes insipidus always have required careful monitoring to prevent problems with sodium, either hypernatremia, in other words, too high sodiums, or hyponatremia, too low sodiums. Either one is bad for you. And in particular, during periods of time of infection with fever, problems with rapid respiratory rate, what's called tachypnea in medicine, these patients may lose fluids more rapidly during periods like that, and they may have inability for fluid intake and therefore need close monitoring in input and output, as well as body weight measurements to make sure that their fluid balance and electrolyte balance is optimized. Unfortunately, in many states and in many counties, there's sometimes been limited accessibility to laboratory testing during this period of time. And so patients who are on things like desmopressin has to be very careful. If they're not able to get laboratory assessments, they should delay desmopressin doses to allow for proper regulation of fluid balance, because one of the potential problems of too much correction of diabetes insipidus is hyponatremia, which can cause serious problems. Patients who have COVID infection and have diabetes insipidus, but are able to control their urge to drink and have intact thirst mechanisms and are alert, can be treated with oral desmopressin instead of the intranasal, because of the congestion of the nasal passages in patients with COVID infection. Obviously, for more severe cases, such as in patients with diabetes insipidus and COVID infections that are hospitalized, these patients obviously will need intravenous or subcutaneous medicine along with fluid resuscitation. You do not want to have dehydration in situations with COVID infection, because the infection itself is associated with what's called hypercoagulability. In other words, a very high propensity for the blood to clot, and that can lead to things like venous thrombosis, blood clots in the deep veins of the leg and in the lung, pulmonary embolus, which can lead to more serious conditions. So many times, such patients may require small doses of heparin to prevent the clotting phenomenon that will sometimes take place. Now, you may have heard that many offices and hospitals are not at full capacity. And what this has led to is that there's a backlog and a waiting list for patients, either established patients or new patients, to get consultation, even with the use of telemedicine. And that same delay has also led to backlogs in patients awaiting surgery. So what to do if you're in the predicament of needing consultation for your pituitary condition, needing to see a specialist, endocrinologist, neurosurgeon, or have been deemed that you need surgery? First thing I would say is calm down, reduce your stress as much as possible. Be in constant, close contact with the surgeon, the endocrinologist, and other physicians to make sure that they are aware consistently of your condition. And this can be done quite effectively with telemedicine, video conferencing, to make sure that they're up to date with your condition and any changes you might have ongoing whilst awaiting consultation in person or surgical procedure, or the initiation of a medical treatment. The other thing that's good to know is that the natural history of pituitary adenomas, in other words, natural history being what happens if you do nothing. We've touched upon some of these in the case of macroadenomas, the large tumors. The biggest threat is obviously the threat to vision with the macroadenomas. The severity of the functional tumors like Cushing's, acromegaly, and then making sure that those assessments of whether or not the vision is threatened or the severity of the medical condition and the associated comorbidities are properly managed whilst awaiting for definitive surgical treatment. There are good temporary, and I would, with the emphasis on the word temporary treatments for Cushing's, temporary treatments for acromegaly, and some long-term treatments also for acromegaly that can be used during this period of time when one is waiting. Prolactinomas we went into as well. There is some medical therapy first line for prolactinomas, which is good and can be used also in the long term. Monitor and report visual symptoms whilst if you are waiting surgical treatment for a large tumor, or you're known to have a large tumor that's awaiting surgery. There is such a thing called pituitary apoplexy. This is a condition that occurs when a pituitary tumor known to exist rapidly expands because it runs out of blood supply, becomes necrotic and enlarges or bleeds into the pituitary tumor cavity, and then you go from having no visual symptoms to having maybe even severe visual symptoms, or in the worst case scenario, one can go blind. So in those scenarios, obviously, you need immediate medical attention, and that patient needs to be moved to the top of the list. If you have to go into hospital during this pandemic, there's some things you want to just be aware of that occur and occurring across the country. You may be in a hospital with COVID positive patients, even if you're not COVID positive yourself. The hospital may have COVID positive patients on another floor, on another unit, or somewhere close by. You may be in a unit that has COVID positive patients. So obviously be mindful of that potential risk. Obviously the hospitals do the right thing in terms of making sure that they minimize cross-contamination and infection. Resources in hospitals have been stretched. Things like services such as anesthesia, for example, because during this COVID pandemic, many patients require intubation, many patients require intensive care unit care, and this requires the skills of anesthesiologists and so on. Radiology and ICU may also be at full capacity and stretched thin, and this may limit your ability to receive these resources in case complications arise during your care. Many hospitals require testing for patients coming into the hospital, even if they are asymptomatic. And they do this for obvious reasons to make sure that they do not introduce infections into the hospital environment where it could spread to others. Other facilities that may also be impacted during this time are rehab facilities, long-term acute care facilities, skilled nursing facilities. Many of these are either not taking patients or are stretched thin already. And if you require any of these facilities, it may prolong your hospital stay in the acute care hospital. Many hospitals are minimizing traffic and therefore will not allow visitors, even immediate next of kin, such as spouses, children, except for very difficult cases such as requiring end-of-life care or patients with behavioral issues, people who are below the age of 18, and if you're going in for certain operations. So you might have to undergo an operation and your wife or significant other or husband or son or daughter is not allowed to be there with you. So be aware of that and plan accordingly. The other thing to be mindful of is that even if you do come into hospital and are scheduled for the surgical procedure or diagnostic procedure, because of the demand for hospital resources during this pandemic, the procedure may be canceled, even on the day of surgery. The other thing is you may notice other things in the hospital that they've reduced elective activities, mine are included, to increase the capacity and the ability to look after patients who are in urgent need with COVID infections. There's been a step up in infection prevention measures, not that they weren't doing it before, but even to a higher level to minimize nosocomial spread, in other words, infections that you get in the hospital. Most hospitals, if not all, are screening patients, visitors, and staff for symptoms and travel history. Hospitals have designated and specific teams and areas for managing COVID patients, suspected or confirmed. They've stepped up cleaning, deep cleaning, more frequent cleaning. Some have modified ventilation in rooms, intensive care units, and operating rooms. There's strict control of traffic in the elevators, in the hallways, in the stairwells, and so on, to minimize all of the potential points of transmission. PPE, personal protective equipment, is being deployed very widely across the board, again, to minimize transmission. And you may notice, or you may yourself, if you're a patient, be required to wear a surgical mask during transportation from point A to point B. Now, a couple of things about endonasal transsphenoidal surgery. This, of course, is the surgical procedure of choice for the majority of patients with pituitary tumors. And because of the particular risks of transsphenoidal surgery, because the virus inhabits the nasal passages, inhabits the nasal sinuses, and it is the nasal passages and the nasal sinuses through which transsphenoidal surgery is performed. That word sphenoidal means sphenoid sinus, which is the sinus behind the nasal passages. And so many patients have had to wait for surgery because these surgeries have been canceled and the backlog has been significant and across many institutions, mine included, and patients have been placed on the waiting list to be done after the peak of the pandemic is over. And so if you may have noticed that your surgery has been canceled or deferred, and a few months after this is all over, those patients need to be reevaluated and re-triaged to determine who's now become urgent, because someone who was non-urgent may become urgent because of the time scale waiting for the procedure. So if you are on a waiting list for surgery, keep a very careful diary of your symptoms, contact and stay in contact with your endocrinologist, neurosurgeon. Be sure to let them know by telephone or video conference, telemedicine, if any changes occur, particularly in things like vision or comorbid symptoms like sugar control with diabetes, blood pressure control with hypertension, and that sort of thing, because those would change the priority that's given to getting the procedure done. Most hospitals and surgeons are only doing the operations that cannot be delayed, in other words, that are deemed urgent or emergent. And if surgical alternatives are available, such as medical treatment temporarily, these have been favored in lieu of proceeding with surgery immediately. If surgery is to be performed, patients are going to require that they undergo testing. Typically, the testing will be done 48 hours prior to surgery. And of course, the results will be received before a determination is made as to whether to proceed with surgery. If the patient is positive, there will be consideration given to seeing whether or not the surgery is truly urgent and must be done. And if it must be done, then it will proceed with the appropriate level of personal protective equipment and precautions that are necessary to safeguard the procedure for the patient, to safeguard the procedure for the surgical team, and so that the surgery can then proceed without the risk of making matters worse for the patient or the caregivers. Endonasal procedures for pituitary tumors through the nose, through the sinuses, are deemed to be a very high risk to both patients and providers, because the virus inhabits the sinus and the nasal passages. And during the procedure, debriders and drills and a lot of instruments and tools are used within the nasal cavity. And these tools and manipulations can lead to further spread, because they can cause aerosolization and spread of the virus particles in the air and through droplet spread, which is highly contagious. And in fact, there have been significant problems with the procedure in other countries reported prior to people becoming aware of this and taking appropriate care. Obviously, the surgeon will maximize the preventive measures to limit the spread, prepare the intranasal cavity appropriately, and minimize the use of tools and instruments that can lead to further dissemination of virus particles. After surgery, as many may know, you have to have post-operative visits to the clinic to inspect the nasal passages, and this sometimes will typically involves endoscopy. And again, because of the risk of spreading virus, the use of endoscopy post-operatively is extremely limited and preferably not used in favor of things such as nasal pledgets, avoiding use of sprays, whether they be decongestant sprays or any other sprays, to prevent, again, dissemination. So the key takeaways is we know that the situation is dynamic. It's an emerging crisis. Things may change. And all I've said is the condition of things as it stands today. It's not meant to be an absolute standard of medical care. It is meant as a guide. In all things, consult your physician, because your particular instance and your particular situation and your particular condition is unique, and those modifications need to be made appropriately to each patient. But what many of the things we've gone over apply to a great deal of the patients with pituitary conditions. I've left my contact information for questions or contacts should you need to. And I know that there have been some questions maybe waiting as well after this presentation. And so with that, I wish you good health. Happy Mother's Day to the mothers, and stay well, keep well. And thank you very much for allowing me to participate in today's webinar.
Hello, Dr. Oyashiku. That was excellent. Thank you so much. There are some questions. First question, is it possible to get a copy of the PowerPoint slides? If you're able to provide the slides to us, we can get them out to the people who request them if you would like. Other than that, we are recording this session, so it will be available on our website after it's edited. So you can go to pituitary.org to view it. Like I said, once it's edited, it should be up soon. And then next question, I have Nelson syndrome. Am I more or less at risk than others with other pituitary issues? I am being extremely cautious, but would like to be a little bit less anxious if possible. Thank you.
Of course, yes. So now, if you have Nelson's, that suggests that at some point in the past you had Cushing's as well. You had Cushing's disease, and then you were treated for Cushing's, and then developed Nelson's. So I don't know exactly your condition, but it's possible that you may also have adrenal insufficiency of some kind as part of the treatment that you, as part of the, as a consequence, not part of the treatment, as a consequence of some of the treatment for the original Cushing's before you then developed Nelson. So if that's the case, then it would seem that your condition and your risk as it pertains right now would be as with a patient with adrenal insufficiency is the most likely scenario. That's just, and we treated some of that when we, in the first couple of slides, with adrenal insufficiency and Cushing's disease.
Thank you. Next question. What is the best scenario for someone who has all the comorbidities and can work from home? Should they literally just stay home?
So yes, if you have all the comorbidities, diabetes, for example, hypertension, for example, lung disease, for example, immune suppression, for example, and you are then in the high risk category, the current guidelines still from the CDC and from the task force says that you as a high risk person should continue to use the social distancing, sheltering in place recommendations, because you are at high risk if you do get exposed for severe a severe set of disease features. So yes, that would be the best thing, is to avoid the exposures if you've got all these comorbidities.
Is that something that people can contact their doctors for a potential note for their employer as things open back up to allow them to work from home a little bit longer?
Absolutely, absolutely. I think in all things such as this, you want to make sure that you have your physician in on all of this. Of course, your physician will know that you have these comorbidities, and so if you are thinking of transitioning away from the stay-at-home guidance, then you should let the physician know, and because if it's not appropriate to let up on that, then they need to be able to support that decision on a medical basis. And so that's why your physician would be very necessary.
Okay. When will it be safe for someone with all the comorbidities? What precautions to take until then?
Oh, until the prevalence of COVID dies down substantially, so that we have an all clear from the public health experts who tell us whether or not the transmission has gone away, or they've developed enough treatments or vaccinations to make it such that that risk is mitigated, then I think you should continue to follow your physician's guidance on that, to make sure that you don't expose yourself to ongoing risk when things are still hot. Because you may be, depending on where you are, you may be in a hot spot, or you may be in one of the areas where prevalence is gone down sufficiently enough to make it safer than other places. So all of that needs to be taken into consideration.
Excellent. Okay, and then this is a comment more than a question. Thank you so much for doing this, so helpful. Next question, if diagnosed with COVID, what difficulties will the patient endure when they use a CPAP machine for chronic obstructive sleep apnea?
Yeah, so again, it depends on the severity of the infection. As you know, many patients with COVID are asymptomatic. In other words, they don't even know that they have anything going on. They're not bothered by it. They don't have anything at all. And maybe somebody drew a test, and then they knew that they had the COVID. Some people have moderate, and some people have severe. But let's say you had moderate symptoms, and you weren't sick enough to be in the intensive care, but you did have symptoms such as congestive nasal passages, because that's where obviously the infection is. Maybe you had a cough and so forth. The congestion and the cough, ongoing cough, may make it difficult for you to tolerate the CPAP or wear the CPAP for prolonged periods of time. So you may need symptomatic treatment to ameliorate the cough, ameliorate the nasal congestion. Consult your physician to see what that's the best treatment for you is, what's most appropriate, so to enable you to be able to better tolerate the CPAP.
I am pan-hypo and work in education. I assume that I need to either have an antibody test or vaccine before returning to the classroom.
Well, the antibody test is available. There are several varieties of that. Best as I know, they're still working out the best of all of the antibody tests and seeing which one has the best prediction and the best false negative and false positive. So that is still an ongoing. So certainly the antibody test is available and you can use that. The vaccines are not available for general use except in clinical trials. So that as far as I know, I don't think you can walk off the street and get a vaccine unless you're in a clinical trial. In terms of your panhypopituitarism, the most important thing in terms of that is making sure that you have the appropriate replacement. So panhypopit means that you need the full repertoire: thyroid, steroid, and I don't know if you've got diabetes insipidus as well, but the full repertoire of replacement, and that needs to be done and titrated by your endocrinologist. And if you've had panhypopit for a long time, then you know that broadly speaking, what doses you're on and that you need to stay on and to optimize your panhypopit. So optimizing your medical therapy is very important and is absolutely important. So that you can do, obviously, but the vaccine is not available, so that's not going to help your ability to go back. And the antibody will only say whether you have the antibodies or not, but we still don't know whether that's going to provide an appropriate level of protection for you to go back confident that you would not be able to contract the disorder. So that's still up in the air.
Okay, thank you. Can you talk more about people with adrenal insufficiency and why they are at higher risk of getting COVID-19?
Yes, so the stress and stress as a broad issue, whether it's traumatic stress, whether it's medical stress, whether it's stress from an infection, the ability for you to cope with stress and mount a stress response is predicated on your ability to make cortisol. And cortisol comes from your adrenal gland. And if you're insufficient, it means that you're not making enough and your body is unable to mount a stress response to fight an infection and to ward off problems from an infection. So you're taking a finite amount of medicine and that's all you have. And so when an infection comes along or a stress situation comes along, your body is not able to make the extra amount that is required. And that's why you need to take more of it. And so you need to be on guard for any infection, for that matter, let alone COVID-19, because in the situation where you have an infection and your body is under stress, you need an extra supply of medication. And if you're on oral medications, you may need to take twice as much. And if you're not able to take the oral when you're sick, you need to have it given to you by an injection. So patients with adrenal insufficiency, I'm sure you know that from having been diagnosed with adrenal insufficiency, your physician will tell you these are the kinds of things to be aware of. If you're sick, if you're feeling unwell, this is what you must do. You've got to wear a bracelet. You've got to have medicines in close supply at home if you need to take extra amounts.
Thank you. And this next question kind of fits in with that, but it's a little bit different. Should panhypopits with adrenal insufficiency consider increasing cortisone dose for emotional stress during this COVID pandemic, i.e. husband in hospital on COVID floor?
Possibly, that's certainly a possibility if you are in a situation with emotional stress, because stress is stress. It comes in various flavors, and then you have to figure out with your physician, talking to your physician, letting him or her know what's going on to determine just how much they recommend you go up on, because each patient will be different in terms of their needs as to how much they need to go up on, depending on the magnitude of problems that they're experiencing at the time and what symptoms and features they have. So that needs to be one of the situations where you need to pick up the phone or get in touch with your physician by telemedicine, and then let them know what's going on. Keeping them informed during this period of time is extraordinarily important.
Excellent, thank you. I have Hashimoto's thyroiditis. Am I in the high risk category?
Not in the high risk category by virtue of the things we talked about, comorbidities. If you don't have one of those comorbidities that we know by the research that has come through with COVID-19, the diabetes, the hypertension, immune suppression, and so on and so forth. In those comorbid conditions, if you have any of those as well, then you need to be aware of the fact that you're in the higher risk category.
Okay, thank you. I have adrenal insufficiency and was prescribed fludrocortisone. I've
Right.
had most common reactions, but since taking and stopped, I now have heart palpitations. Is this common?
So you were on fludrocortisone and you did what now? What, can you repeat the question?
Yeah, so I have had most common reactions, but since taking and stopped, I now have heart palpitations. So it sounds like I started taking the medication and then stopped the medication and now have heart palpitations after stopping it.
Yeah, you need to, the best advice I can give you is that heart palpitations need to be evaluated by your physician to make sure what the genesis of it is, and not assume what it is caused by, because there are various possibilities. And so the best thing is to get it checked out, and don't just assume that it's because you stopped or started something. You may be right, but the best thing is to get it evaluated properly. Make sure you're on the right track and not make an assumption.
Thank you. I'm not sure if it was covered, but does having a prolactinoma put me more at risk? I've been dealing with this for 6+ years, and I've just now found a doctor who has started to address the problem. My blood tests have always been inconsistent, so we're not sure if I have thyroid issues or anything else. Thank you.
Well, the prolactinoma on its own, just per se, typically doesn't lead to one of the comorbidities. Just prolactinomas themselves would typically cause problems with cycles or what's called galactorrhea or breast milk discharge or infertility. But if you have classic hyperprolactinemia symptoms, those particular symptoms and findings are not in the high risk category. Now, you could have a prolactinoma that's what's called a co-secretor, that also secretes, say, an excess of ACTH or an excess of growth hormone. So it's not a pure prolactinoma, although it has the prolactinoma itself as well. So in those scenarios, those would lead you to be into the higher risk category because of the growth hormone component or the cortisol component. So a pure prolactinoma, no, but a prolactinoma that's associated with some other of these could put you in that risk category. So that needs to be checked out. Get your labs evaluated by your physician. Make sure that you're purely secreting just the prolactin, and it's not a prolactin plus something else.
Okay, thank you. I am hypopituitary with secondary adrenal insufficiency. It is my understanding that I am not immune suppressed because the hydrocortisone that I am taking is replacement dose. Am I still at higher risk for COVID-19?
Yes, if you were to have, if you were to get the infection and you weren't asymptomatic and you got, say, God forbid, a moderately moderate infection, and you had symptoms like fever and shortness of breath and cough and that sort of thing, your secondary adrenal insufficiency would now have to be managed as if you were sick, and so your dose of replacement, even though it was fine when you were not sick, now you're sick, that dose would then need to be increased to match the situation that you're now facing. In other words, a bona fide infection from COVID-19. So the situation changes if you get infected.
Okay, thank you. Follow-up comment from the question before about adrenal insufficiency and fludrocortisone. They're asking if sun rashes are common.
Sun rashes are common with fludrocortisone.
Yes, I believe so.
I don't know the answer to that.
Okay, and the same person said they're now taking hydrocortisone 25 milligrams daily.
You're taking hydrocortisone prescribed by your physician, 25 grams daily?
Yes. I get
So
maybe
the question is,
the
should you take it or not take it? You should take what your physician prescribes.
I think initially they were taking the fludrocortisone and are now taking the hydrocortisone.
Yeah, you should, or what I would do is I would say in this scenario, I would defer to your physician because they know you best. And I hesitate to tell you not to take what your physician has prescribed because they know you best. So I think that's the best thing I would advise you to do is to revisit that with your physician and make sure that he or she doesn't have a clear reason to prescribe that to you, so that you don't get advice that's not tailored to you. You know, obviously you need something, then you're better off taking it. And I don't want to tell you not to take something unless I'm sure.
Okay, thank you. I am 2 years post-surgery for Cushing's disease and 1 year post-adrenal insufficiency. Do those make me more at risk or not?
Yes, adrenal insufficiency does.
It says 1 year post-adrenal insufficiency, so I'm not sure if it has
Are you
resolved.
you're no longer taking replacement? If they're no longer taking replacement and they're back on their own steam with normal levels, and it's 2 years post-surgery, 1 year post-insufficiency, and they're no longer adrenally insufficient, then yes, they're no longer adrenally insufficient. So they're within the range of normal, and they're able to mount a steroid response, and that's been evaluated by their physician. So the adrenal insufficiency is over. But typically, patients with Cushing's will have adrenal insufficiency for a while, and then will require hydrocortisone, and in some cases may require extra hydrocortisone if they're just on the margin. But if the replacement is no longer necessary and they're not on the margin and have good cortisone reserve, they've had a cortisone stimulation test, for example, then and the physician doesn't deem it necessary, then they should not be at a higher risk.
Okay, thank you. With pan-hypopit, if I am hospitalized with COVID, which hormone deficiency will be the most difficult to manage? I feel like it might be diabetes insipidus.
If you have diabetes insipidus, yes, it could be difficult to manage because depending on the severity of the COVID, it may be difficult to manage your fluid and electrolyte levels. But clearly, cortisol is still very, very difficult to manage if you're pan-hypopit. That can also be challenging as well. So I don't think it's either one or. It could be both. And they're just as challenging in both scenarios.
Okay, thank you. How should Cortef dosage change if you have COVID-19? Should I triple dose due to adrenal insufficiency?
Again, this is one thing I want you to make sure you double check with your physician because patients differ there, and cortisol dosing is based on gender and surface area and so on and so forth. But in general, when patients are insufficient and fall ill, whether it's from COVID-19 or in fact anything else for that matter, the usual recommendation for sick day adjustments is a doubling of dose, right? But my point with saying that is not for you to take away as that's the only modification. It may differ from patient to patient. And so you need to make sure that that guidance that you have in terms of what the dosing should be predicated on the guidance you have from your physician who knows your condition best. But in general, a doubling of the dose is usually what is required.
Great, thank you. Is there a way to increase my immune system, reduce stress, eating properly, vitamins, etc.?
Yes, you mentioned several good things: in reduce stress, vitamins, rest, good diet, etc. Yes, those are all wonderful things to add to your repertoire of immune boosters. And then, there are probably a host of other things, some proven, some are not proven, that have been put out there. But the ones you mentioned are very good.
Are there particular vitamins that you would recommend?
I think just a balanced vitamin regimen, with the recommended, what I call the RDA's, recommended daily allowances, and making sure that you obviously eat a balanced diet, etc. But I wouldn't recommend any one to the detriment of another.
Okay, great. Thank you. Good question. I recently had my hydrocortisone decreased by my endocrinologist. I've had a bilateral adrenalectomy in the 1980s due to stress and an increasing blood pressure overall. So far, it seems to help overall. How does this mesh with increasing cortisone during stress?
Okay, so with a BLA, that takes away your adrenals, your bilateral adrenalectomy, and hence you are on the supplement, the hydrocortisone supplement, on a consistent regimen. Going back to what we said, you are adrenally insufficient, making up that deficit with supplement. And in the event that you fall ill or contract an infection of some kind or under stress of some kind, you will need to up that dose. And that dose is very important to increase during those times of stress, because your body is not able to mount that stress response that you need to fight infections, to cope with assaults on your immune system and assaults on your physiology, and that's where the need for that comes.
Excellent. Do all these pituitary disorders affect our brains? They seem to be getting things mixed up a lot. I am hypopituitary after craniotomy in 1986, radiation, and now diabetes insipidus and adrenal insufficient.
Yes, so you can have effects on the brain, the central from a pituitary condition. One of the most classic ones, the excess of cortisol in patients with Cushing's disease that causes cognitive, memory, executive function problems, and shrinkage or atrophy of the frontal lobes, which you can actually see on MRIs. The other thing that you mentioned that causes problems with cognition, memory, and executive function are patients who undergo radiation. And I thought I heard you mentioned radiation as well. And so radiation is also well known to cause problems with cognition, memory, ability to remember, cognition, knowledge, and executive function, things like judgment, decision making, and those sorts of things. So that's a possibility as well.
Okay, thank you. Next one's, I don't see any more questions. Give another few seconds for people to get more questions in, but there are several thank yous. Thank you so much for Dr. Eskew for volunteering his time to present this very interesting and informative webinar, and to the PNA for organizing this. More thank yous.
Thank you very much. It's been a pleasure being with you this afternoon.
Thank you so much for the presentation and for answering our questions. Looks like that concludes the questions. So Dr. Eskew, excellent presentation and questions. You guys are getting great at these questions. Those are also very good, and the answers obviously great. This concludes today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you would like to share it with family members or friends, it'll be available on our website, www.pituitary.org. After it is edited, there'll be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us. Happy Mother's Day to all the moms out there. Everybody enjoy the rest of your day, and thank you so much, Dr. Eskew.
Thank you very much.